All right, everyone. Welcome back to COVID Corner. We have a special guest today, Dr. Rich Severin, so I'll let him introduce himself.
Hi, and Ashley, thank you for having me on the I guess podcast or corner or video podcast. But so I am Dr. Rich Severin. I'm a physical therapist here based in Chicago. I am a faculty member at the University of Illinois Chicago Department of Physical Therapy and a PhD candidate in our rehabilitation sciences program, where I study respiratory physiology or cardiorespiratory physiology and obesity and in multimorbidity, but mainly obesity. And I'm also a clinical assistant professor at Baylor University in their hybrid doctor of physical therapy program, which is based between Dallas and Waco. We're kind of, our facility is now in Waco, but we do some stuff in Dallas too.
So Rich, do you want to tell us a little bit about your newest paper?
Yeah, absolutely. So, part of my research or a large part of my research is looking at physiological responses to exercise. So in morbidly obese patients, so I work with patients undergoing weight loss surgeries. So on average, our patients are BMI of 50. So these are people who've struggled with weight loss for many years, tried multiple different solutions, exercise, diet, just can't find the right solution. So surgery is an option for them to lose weight. Just working with that population, we realize, and the evidence talks about this, is that breathing is often impacted in these patients. We're finding, just in a general synopsis, that the demands of breathing in a patient with obesity can be as high as 3 times what it is in a normal healthy or someone with a normal body weight or a lower lean body weight. We'll try to avoid that term normal, right? And there also may be impairments in the ability to generate force. So basically what you have is you have a higher demand placed on breathing and potentially a lower supply. So you have a little bit of an imbalance. Now typically that just results in dyspnea. They have issues with getting around, and it's a frequent complaint or issue with patients who are obese that when they get up to walk up the stairs or they walk a block, they get really short of breath, and that's because of that imbalance, as well as other components too. Now, why that's important is, again, typically we have a very large reserve to generate pressure needed for breathing. Most humans can generate about 100 centimeters of water, give or take, and it only requires about 5 to 10 centimeters of water to take in a normal breath. And to fully recruit the lungs, depending on what you read, 40 to 50. So we've got a very large reserve, and we operate a very high efficiency for breathing, very, very high efficiency. Now, when you have an obese patient, again, we have that supply-demand imbalance. When you throw on an acute lung injury like COVID, which can cause widespread changes to the lung and the airways and all kinds of other issues, if you're operating really close to your margins and you have an accident, you're going to have problems. That explains why we see so many patients, or may explain why we see so many patients, with this infection with obesity that have a higher case fatality rate or higher complications because of they just don't have the reserves. So when something bad happens, they don't have that ability to accommodate. Because not everyone who gets COVID infection ends up on a ventilator or ends up in a hospital. I think Cuomo, right? Or Chris Cuomo, which one's the CNN guy? It's Chris Cuomo, right?
It's Chris, yeah.
Yeah. He got it. I don't think he ended up in the hospital, right? He was able to kind of, I think, do stuff at home, stay active. But if you're obese, again, or maybe you have other comorbidity like chronic lung disease, or you smoke, or you're just older, we see respiratory muscle performance decline as you age. So realizing that, and this is what I do pretty much every day in the clinic and in research, this may, just looking at the data, looking at the trends, I'm like, I think respiratory muscle performance could be a big issue here. And when we highlight in the paper, you look at some of the key guideline statements from the American Thoracic Society, the European Respiratory Society for dyspnea. It doesn't include respiratory muscle performance, despite the fact that both societies have published guidelines on how to do it. There was actually a very elegant one that was done last year by the ERS that soup the nuts on everything, how to assess the respiratory muscles, but it's not in their guidelines for dyspnea. They include other things like spirometry or questionnaires. So, we have, again, a large population of people with obesity, 66, or obesity overweight, 66% of the United States population of obese, overweight. a large population with chronic morbidity or multimorbidity, I think it's 6 in 10 with 1, 4 in 10 with 2 or more. So we have a large people with this poor baseline health, which is related to impaired respiratory muscle performance. However, we don't routinely screen for it. So my thoughts are, well, why don't we, for patients that are at high risk for these serious complications from a viral infection, screen them to identify, is there weakness? Because we think respiratory muscle performance or respiratory muscle weakness or performance impairments are rare, but they're more common in these populations. But we don't want to just screen everybody. So we want to screen these higher risk patients with multimorbidity, especially with obesity, and then anyone with dyspnea. And then see if there's weakness. And if there's weakness identified, to implement a prophylaxis training program. This could be done, chronically throughout the year, just like an exercise program they do. What we think maybe even a better, more tenable solution is at the onset of an outbreak or maybe prior to flu season, to start like an intensive inoculation, if you want to view it that way, program. Because there's been evidence from the preoperative literature that even 5 days of training pre-surgery can improve MIP and improve post outcomes. There's not a lot of data on how this impacts viral infections, but there is enough existing evidence and biological plausibility for this theory that we have to kind of be valid within a reasonable level of certainty. So that's what it's about.
Yeah, that's really awesome. And where can we find your paper?
Yeah, it was published in the American Journal of Medicine. It was published 2 days ago. It was kind of by surprise. We knew they were going to be putting it online early. I think the final print version is going to be coming out in like September, but they're going to put it online early. It's more common enough journals to do this. And what was I filling out? I was filling out like a grant application, and I had to include like publications. And I went to my ORCID, which is like your online registry for your publications, and to pull up another one. And I saw this like flash on there. I'm like, I didn't get a notification from the journal this is out yet. It must have just come out, so then we shared it about, and it's been really well received. Some of the people that have been sharing and retweeting it, it's been kind of awesome. Like it's surreal that you put out a paper that you think is a good idea, and then you see what other people think about it, and they think likewise. So,
what's the title of the paper?
Well, the title of the paper is Respiratory Muscle Performance Screening for Infectious Disease Management Following COVID-19, a Highly Pressurized Situation. I like to always put a little play on words in most of my titles. So
that's awesome. I look forward to reading it. I haven't gotten to it yet, but it is in my queue to read.
Awesome. Thank you.
We do want to ask a little bit more about this obesity and COVID link. So we're hearing a lot that if you are obese, you have a higher chance of getting COVID. What are your thoughts on that?
Yeah, so there's a lot of theories out there, on how this virus makes its way into and through the body. Some people postulate it has to do with these Ang2 race 2 receptors. Obese people often have hypertension due to some of the effects of perivascular adipose tissue, which increases and becomes dysfunctional in obesity. It's actually what we study a lot of in our lab, looking at microvascular function in an obese model. So a lot of these patients are put on angiotensin or ACE inhibitors or ARBs, and those basically free up the sites for the virus to potentially bind. The other side is if you're just a poor health, you might get infected, right? You and I might get infected, but we may be able to develop or have a strong enough immune system to fight it. If you've got chronic conditions, it may lead to worse sort of physical manifestations of this virus. The other thing that I think people aren't thinking of when we're don't want to give away too much just yet, but because we're working on a paper for this, is the role of sleep health. We know generally that your antibodies, especially after if you get a vaccination, you produce your antibodies during sleep. Mm-hmm. And obese people, and obesity is one of the leading risk factors for impaired sleep quality and quantity for a lot of different reasons. So we think it could be that as well. So that's why I think it may have to do with some of the just poor baseline health and immune system issues, as well as maybe you're on a medication that increases the binding sites for that, for that virus. as well as your ability to fight it, because maybe you don't produce antibodies as you would, you and I, if we got infected, our bodies would recognize that foreign antigen and create this antibody. To fight it. So there's probably multiple factors involved here. But I think maybe those three, in my estimation, I think are some of the big ones.
Yeah, that's interesting. And you have to think about patients who were hospitalized that are morbid obese with COVID and getting like ICU delirium and things like that from lack of sleep. I think that's kind of the perfect storm.
Yeah, you're absolutely right. It's one thing that I was trying to bang the drum on early, that like, man, like just managing this is not going to be the only battle we fight in this war and this infection. Like, we highlight this in the paper that if you look across, and it depends on the facility, but these are national average. I think that ICUs and mechanical ventilation resources are typically at 62 to 66% utilization on a normal day. Like these things don't go empty, right? The utilization has increased, every couple percentages every year. We have an older, more sicker population. It would make sense that our resources for those, to manage acute issues with those conditions are high. Every 40 seconds, someone in the United States has a heart attack, right? Yeah. So we have, this poor baseline health. And then, so we have a high utilization, and it's getting in there too. Like, the ICU is a very different situation. It's very just different than living, right? And, you've got maybe, no windows, right? Your circadian system's all thrown off, which throws off everything. We know mechanical ventilation in some patients can induce rapid and profound weakness of the skeletal muscle, of the respiratory muscles within 18 hours. So if you got, again, like maybe you're that obese person, you've got that imbalance, acute lung injury, and then you're ventilated, you're going to have some problems. And you're a respiratory therapist in training as well, by your training as well, that obese patients are difficult to ventilate in general, notwithstanding a viral infection on top of that. And maybe, sepsis if that gets to their, the other organs, their bloodstream. So getting these patients stabilized is one thing, and then dealing with all the secondary complications, because we're learning, this virus is wild. It may have neurological impacts. It may make its way into the nervous system. I'm working with some colleagues in Buffalo, looking at that. There may be some impacts on the heart, causing myositis and arrhythmias and all kinds of crazy things. The vasculature. These are complex patients, and the post management is going to be a complex one for sure.
Yeah, and that kind of answered our second question. Will obesity make recovery more difficult from a physical or respiratory function standpoint?
Yeah, I would say absolutely, for sure. These patients, even it's kind of what sparked my interest in going this route for my dissertation work, is just, talking to my anesthesiology friends, my respiratory therapist, and just seeing it when I would work in the hospital and as well in the outpatient side, these patients are tough to ventilate, they're tough to wean. And now you throw that, which we have a large portion of these patients in the ICU, it's going to be tough. It's going to be tough.
Awesome. Well, thank you so much for coming on, Rich. I know we value your expertise, and we all look forward to reading your newest paper. It sounds so exciting. Yeah,
I'm excited. And I'd say too, this is a time for PTs to brush out those. I've got a few of these devices here. Your respiratory muscle assessment devices. You've got the Pro2 trainer here and the Power Breathe as well. These are all things that are within our wheelhouse to assess and train. I think there's going to be a big role for that as PTs, and we put some resources out. I think Larry's got a paper or got a video coming out. There's free resources out there to get good at doing this stuff, and these companies have existed for years. Get sharp at doing this, because I think that's going to have a big role, and we this is something that's fully within our wheelhouse. It's the respiratory muscles are a muscle like anything else. They can be assessed and they can be trained.
Absolutely. Yeah. Thanks so much, Rich.
All right, so take care. Thanks, Ashley.